foundation consists of the history. You should see them on your screen, 6 items: history, examination, diagnosis, goals need to be set for the patient. You need to list the services you're rendering plus the clinical rationale. Number 5 on this list is where we're going to be getting into a lot of detail, and then the schedule of care. So let's just start with the history. Mr. Jones walks in with low back pain and neck pain. Okay. So what are you going to do? You're going to ask Mr. Jones, how did it start? When did it start, right? That's called the history. Some of you call it the consultation. There are 4 levels of consultations or histories: a problem-focused, an expanded problem-focused, a detailed, and a comprehensive. So before you could even bill the therapeutic procedures and modalities, you need to talk to the patient. You need to do a history. So according to the E&M guidelines, there are 4 levels or 4 types of histories. Now, I'm just going to focus right now, just to keep it simple, on CPT code 99203. That's the most commonly billed new patient CPT code. So a detailed history means that you have spoken to the patient and written down at least 1 chief complaint, 4 items in the HPI column, which is the history of present illness. 2 to 9 systems need to be reviewed, and 1 item from the past history, family history, or social history. So again, when you are writing down what the patient has told you for the initial visit, again, back to Mr. Jones. So Mr. Jones presents today complaining of low back pain and neck pain. There are your chief complaints. The HPI, the history of present illness, or maybe in chiropractic college you were taught this as the OPQRST. So Mr. Jones says the pain is radiating into his thigh. It's sharp. It's worse in the morning. Ice makes it feel better, right? So you're going to go through the OPQRST or the HPI, history of present illness. You need to write down 4 of those. That's for CPT code 99203. Also, when you are documenting the history or consultation portion of this visit, you need to review systems, 2 to 9. According to the E&M guidelines for CPT code 99203, you need to review 2 to 9 systems. And then we have the past history, family history, or social history. Just need to document 1 of those. So what's a quick example of a past history? Mr. Jones, have you ever had any trauma to your spine? I mean, that's a question that every chiropractor, physical therapist, orthopedist, anyone treating patients with musculoskeletal pain, that is a required question. Have you ever had any trauma, injuries to your spine? So that's an example of a past history. You need 1 of those from that category: past history, family history, or social history. So that's the history portion of the visit. So please make sure you're documenting all of that. Next part of the care plan, and you see the little photo in the bottom right corner, that's a table. You're setting the table. So we need to continue to set the table before we could start billing and performing therapeutic procedures. So the next step is the exam. Okay, so you finished talking to the patient. Now you're doing an exam on the patient. Again, according to the E&M guidelines for CPT code 99203, there are 4 levels: problem-focused, expanded problem-focused, detailed, comprehensive. 99203 means you did a detailed exam. A detailed exam should include 12 exam findings. They could be positive or negative, but you need to include 12 exam findings. But remember, you need to know what constitutes a finding. If you say, Mr. Jones, turn your head to the right, and it feels painful and restricted, and then you say, okay, Mr. Jones, turn your head to the left, that also is restricted, painful. That does not, I repeat, that does not count as 2 findings. So please make sure you're aware of what constitutes a finding. That's all in the E&M guidelines that I've been referring to. So anybody listening to this presentation, if you would like to get a copy of these E&M guidelines that I've been referring to, just send an email to amy@targetcoding.com. That's AMY at targetcoding.com, TARGETCODING.com, amy@targetcoding.com, and she'll send you the E&M guidelines that I've been referring to. So with the exam, you need to know what constitutes a finding. So I'll show, I'll throw out a few others. So if you find tenderness in the neck and the lower back, there's 2 findings. You do reflexes, that counts as a finding. Orthopedic and neurological tests do not count as individual findings, especially if you're doing range of motion. Range of motion counts as a finding. So make sure you're aware it's a finding. You need 12 for 99203. Now, some of you may be saying, well, I bill 99202. Well, you only need 6 exam findings. You may be billing 99201. I don't recommend it, but you may be billing 99201. That requires 1 to 5 findings. If you're billing 99204, 205, it gets pretty complicated because it's a comprehensive exam, and then in that case, you have to perform all elements identified by a bullet within these guidelines that I'm referring to. You have to document every element in each box with a shaded border and at least 1 element in each box with the unshaded border. Again, these shaded borders, these elements, they're all in the E&M guidelines that I'm referring to. Now, the next step, so we did the history, we did the exam, now comes the diagnosis. Part of the diagnosis is coming up with decision-making, like what are you going to do? You're going to see the patient once a week, twice a week, 3 times a week. You're going to recommend MRIs. You're going to recommend DME. You're going to recommend back braces, TENS machines. So this is part of decision-making, and also part of the decision-making is coming up with a diagnosis. So, according to the federal guidelines on medical necessity, the items or services being provided must be reasonable and necessary and in line with the diagnosis that you choose. Your diagnosis is very important. It has to be accurate. It should link with the procedure codes you're billing. You should try and use high-value diagnosis codes. There are certain diagnosis codes that pay more than others, so you should be aware of it. If you want to learn more about that, let us know. The next part of the care plan is the goals. You have to set goals for patients. You could start with the intake form, gather baseline numbers in the consultation, ask questions about their activities of daily living, gather baseline numbers in the exam. The goals should be feasible, include a time frame, update the goals as improvement occurs. You could use range of motion. You could use outcome measurement forms. There's a lot of ways, there are many ways to document goals, and monitoring them is very important. It could be the difference between getting paid or not. It could be the difference between having to give money back to insurance companies and not, by creating goals and then updating them as the patient improves. You have to show that the care you're providing is working. You have to show that what you're doing is providing long-lasting benefit, or else you won't get paid. So you need to create goals and show that you're striving towards the goals, and if you're meeting the goals. Next is that you're going to be rendering. So the services, we're talking about what? Ice packs, hot packs, EMS, traction, manual therapy, massage therapy, therapeutic exercises. We're going to be touching on these in a few minutes. What else? DME, TENS machines, back braces, x-rays. I mean, what are you going to be providing to the patient? Acupuncture, strapping, taping, kinesiotaping, active release technique, hydro massage therapy beds, laser therapy, functional evaluations. If you have MDs in your practice or DOs, you may want to do trigger point therapy, lab work. How about weight loss and nutritional consultations? So these are all part of the services you're going to be rendering. You should list what your impression is and what you think you're going to be doing. And then the visit schedule, that's the easiest part. The visit schedule, 3 times a week for 4 weeks. You know, you need to include the frequency and duration. So that's setting the table for the procedures and modalities. Now we're going to start talking about the specific procedures and modalities. So let's start with the modalities. Supervised modalities, to be specific. There are 2 types of modalities, supervised and constant attendance. Let's start with the supervised application of a modality that does not require direct one-on-one patient contact. First one is hot packs and cold packs. Same CPT code 97010. Next is mechanical traction 97012. By the way, if anybody has any questions, type them in and hit send, and we will get to all the questions at the end of today's presentation. Sometimes there are tons of questions, sometimes there aren't. So we'll see later. So traction is a very popular code, very common code used by chiropractors and physical therapists. Again, you could set the patient up on traction. This does not require one-on-one contact, so you could set the patient up on traction and you could walk away. You don't have to stay with the patient. You don't have to stay in the room. You could set the patient up on traction, close the door, leave the patient unattended. That's okay with supervised modalities. Now, you should understand the clinical rationale for every procedure that you bill. So the clinical rationale for traction is to separate and stretch the spinal segments. Traction is used to help promote joint hydration. It's helped to promote gliding of the joint facets. These are the key words you should have in your documentation. If you want to learn more about that, contact us. We have the clinical rationale and the documentation suggestions for every physical therapy CPT code, and we also have the associated diagnosis codes, as you'll see here on the screen for traction. The associated or linked diagnosis codes are neck pain, disc degeneration, and sciatica. Just a few. There's a whole bunch more. You should know all of these. If you're using traction, you should know every diagnosis code that links to traction. It'll substantially help decrease denials. Okay, so now we have other supervised modalities that do not require one-on-one contact by the provider. Other examples here are unattended electrical stim. There are 2 codes for that. 97014 is the CPT code, and then some areas have said we need the HCPCS code. That's G0283. So you should be aware of which companies require that. If you need help with that, let us know. Vasopneumatic 97016, 97018, paraffin, Whirlpool 97022, diathermy 97024, infrared 97026, ultraviolet 97028. So those last 6 codes are not that commonly used, so I'm not going to get into too much detail on those. If anybody has any questions on those supervised modalities, please send in your question. And by the way, if you think of a question after the webinar, no worries. Send your question to Discount Medical Supplies, and they'll forward it to me. Or I guess you could send it directly to Target Coding. The email would be, you could also send that to Amy, amy@targetcoding.com if you think of a question after the webinar. And now we have the constant attendance modalities. Okay, things change here. Now things are going to be different. This is the application of a modality that requires direct one-on-one contact by the provider. So the first one here is 97032. Application of a modality, 1 or more areas, electrical stim each 15 minutes. So you either need to do the electrical stim through the ultrasound head, or you stay in the room and you turn the pulse meters up or down. And remember, you need to also put in the clinical rationale for electrical stim, which would be to reduce edema, break up adhesions, reduce spasm, helps with the reduction of post-traumatic inflammation. So, remember those key words you need to use within your documentation to substantiate code. And then we also have, there's a little background noise just to let you know. I hear some noise in the background, so please everybody mute your phones. Next we have iontophoresis, contrast baths, ultrasound. That's a very common therapy, constant attendance modality. 97035. Anybody have any questions on that? Send them in. We have Hubbard tank, unlisted modality. Sometimes you need to use an unlisted modality for procedures that just don't have a CPT code, like laser, for example. Cold laser, there's no specific CPT code for cold laser, so you would need to bill 97039, or there is a HCPCS code for cold laser. If you want that code, just send an email to amy@targetcoding.com. Next is, now here we go, the therapeutic procedures. This is where things change. This is where you're going to make most of your money, so to speak. These codes pay better. They also show patients how to exercise properly. They also can include showing patients home care. So insurance companies are willing to pay very nicely for these procedures because they know they work and they know that it will hasten the healing process so the patient doesn't have to come in forever. So now you could have a patient come in forever, but some of it is medically necessary where you can bill and some of it isn't. So you have to make the determination. Once it becomes patient reaches the maximum improvement, then just transfer the patient over to wellness and have them come in on a cash basis and continue to do the therapeutic procedures. So therapeutic procedures are a manner of effecting change through the application of clinical skills and or services that attempt to improve function. So the first one here is 97110, Therapeutic Exercises. Very good code, very commonly used by chiropractors and physical therapists. The purpose is to increase range of motion and flexibility and strength and endurance. The patient could be doing this in an active situation or active assisted or even a passive approach. These exercises have to show that you're improving range of motion and flexibility. So what does the patient have to not have, right? If your goal is to improve range of motion, that means the patient had an inability to perform normal range of motion. If you want to increase something, first you have to determine that the patient has a decrease in it. So please be aware of it. You should not be doing or billing therapeutic exercises on a patient if they have full range of motion. So any questions on that, please send it in. So that's the first therapeutic procedure code here, 97110. The documentation must show object of loss of motion. There are certain diagnosis codes that link with therapeutic exercises. There are 3 examples right there on your screen. There are about 150 diagnosis codes that tie in or combine with 97110. Please contact us if you would like that entire list. It's part of a book that I've written. We don't give that away for free unless you're a member of Target Coding. You can get that book. If you're a member, it's included with membership. If you're not a member, you can buy it, which gives you all the diagnosis codes for the procedure codes. Next is 97112, Neuromuscular Reeducation. Neuromuscular reeducation of movement, balance, coordination, kinesthetic sense, posture, proprioception. This is a very good code. I think this is something that you deserve to be paid for. Some insurance companies give doctors a hard time on this one, but if you know how to bill it, you know how to strategically use modifiers and use certain diagnosis codes and link them properly, you should be able to get paid. So this is a very good code. It's used to improve balance. So, okay, here we go. If you're billing an insurance company 97112 because you're improving balance and coordination, what should the patient present with? An inability or decreased balance and coordination, right? So please be aware of that. And now we have a whole bunch of other codes here: aquatic therapy, gait training, massage, unlisted modality. Well, let's go through each one. Aquatic therapy, well, this has to be done in a water environment, so most of you are not going to be billing this. These are exercises in a non-weight-bearing position. Gait training is a very good code. It could be used for patients whose walking abilities have been impaired by some sort of neuromusculoskeletal abnormality. Patient might have a chronic, debilitating condition where safe ambulation has become a concern. The patient needs help in the use of a walker, a crutch, or a cane. The patient has suffered some sort of musculoskeletal trauma, and gait training is required in order to get the patient ambulating better. So gait training is a very good code. Massage is also a very good code. Physical therapists get paid by Medicare for 97124. Medicare pays for massage. Yes, you heard me right. Medicare pays for massage therapy. But realize it has to be medically necessary massage therapy. There's a big difference between medically necessary, insurance reimbursable massage therapy and spa type, wellness type, non-insurance reimbursable massage. Make sure you know the difference, especially if you're billing insurance companies for massage. Though, if any of you listening to this presentation are billing any insurance company for 97124, I strongly recommend you buy my book on how to add massage therapy to your practice, because I go over extreme details on how to show massage being a medically necessary service so you can get paid and not worry about having to give the money back. So that's massage. Next, 97139, another unlisted procedure code that you might have to use if you're performing a service that doesn't have a specific code. And just a little heads up, when it comes to CPT coding, you can't just approximate or think that it's probably the right code. You have to pick a specific code for the service you are rendering. You can't merely approximate. Now, if you cannot find a specific CPT code for the procedure you're performing, that's when you have to use an unlisted or an unspecified code. Manual therapy, excellent code. This is one of the most commonly used codes by chiropractors and physical therapists. This is deep, soft tissue mobilization, manipulation, manual lymphatic drainage, manual traction, myofascial release, helps stretch, shorten connective tissue. So those are the things you should be putting in your notes. Now, for chiropractors, let me just give you a little heads up here. The National Correct Coding Initiative that if manual therapy, massage, or NMR is going to be performed on the same day as an adjustment, it should be in a separate anatomic site. So if you do that, add the 59 modifier to any one of those three codes. Physical therapists don't have to worry about that as much because there's no bundling in a physical therapy practice with the chiropractic adjustment codes. Next, we have the group therapy, 97150, 2 or more people exercising in an open area. You have to identify the specific treatment, how the treatment's going to restore function. Group therapy consists of simultaneous treatment to 2 or more patients who may or may not be doing the same activity. So the doctor, or if your scope allows, a staff member is dividing attention among the patients, providing only brief intermittent personal contact, then you're going to bill both patients 97150. Next is 97530. That's Therapeutic Activities. I don't call it kinetic activities. Some people say that. I call it what the AMA CPT code book says it is. I don't call this kinetic activities. I call this therapeutic activities. Direct one-on-one patient contact by the provider. You're using dynamic activities to improve functional performance. See, that's the key right there. You have to be directing the patient to use dynamic activities. What does that mean? Certain motion, certain exercises, certain activities that relate to an activity of daily living that the patient is doing in their normal day. So it's used in this sense. Some experts call this ING code, ING, because it relates to bending, lifting, carrying, reaching. So the activities are directed at a loss or restriction of motion. Example might be, we want to increase flexibility of the patient's quadratus lumborum muscles while activating and stretching the hamstring muscles to improve the patient's capacity for walking and standing. Next is ADL code, I call this, or Activities of Daily Living. This is Self-Care Home Management Training 97535. The patient must have the capacity to learn. They must be able to understand what you're teaching them. So showing patients how to bend, lift, whatever you're showing the patient, it should be hastening the healing process. Home exercises, how to bend, how to lift, how to get in and out of a chair, in and out of a car. Now, let me share with you a little bit about timed codes. Again, anybody have any questions, send them in, and we'll get to them at the end. According to CMS, 1 unit is 8 to 22 minutes. 2 units is 23 to 37. 3 units is 38 to 52. 4 units is 53 to 67. So please do not automatically assume the insurance companies you're billing use this format. You need to contact every insurance company you bill and find out what their rules are on time codes. So now, if you would, well, we'll just leave it at that. Now, I'm going to give you a little surprise quiz. See how you do. 10 minutes of myofascial, 10 minutes of therapeutic exercises, 5 minutes of traction, and chiropractor adjusts C5T1 in the right SI joint. How would you bill this? Well, here's my question. Can you bill both the exercises and the myofascial release? The answer is no, because the total is 20 minutes. Remember, 1 unit is 8 to 22 minutes. So you could only bill one of the codes, 14 or 110. And then you'll bill the 97012 and 98941. Next, re-exam, 15 minutes of traction to the neck, 15 minutes of traction to the lower back, and you would adjust C1 and L5. This would get billed as 99213. Mechanical traction only one time, even though you did it for 30 minutes, and even though you did it in 2 separate regions. You can only bill it one time, and then there's the 2-region chiropractic manipulative treatment code. Next, 10 minutes of massage, 10 minutes of therapeutic exercises, 10 minutes of therapeutic activities, and chiropractic adjustment to T10 and L3. Can you bill all 3 of those procedures, the massage, the exercise, and the activities? The answer is no, because 30 minutes equals 2 units. So appropriate billing for 30 minutes is 2 units. You're going to select 2 of the codes to bill, since each will perform the same amount of time. And 98940 for the 2-region manipulation. Next, 20 minutes of myofascial, 20 minutes of therapeutic activities. That's 40 minutes. How do you bill that? Well, total up the amount of time. 40 minutes falls in between 38 and 52, so that's 3 units. So I can bill 3 units, but I only did 2 services. How do you bill this? Well, the appropriate billing for 40 minutes is 3 units. Each procedure was done for at least 15 minutes and should be billed for at least 1 unit, but the total allows 3. Since the time for each is the same, choose either code for 2, bill the other one for 1 unit, do not bill 3 units for either one of the codes, and then we have the 98941 for the 3-region manipulation. All right, just a few closing comments. You must check with all the carriers you bill prior to submitting claims based on the information provided in this presentation to ensure that it is compliant. Target coding does not guarantee that the information provided in this presentation will guarantee payment from any insurance carrier or patient. Target coding is not responsible for any insurance carrier or managed care organization laws, rules, and guidelines that may change following this presentation. So please understand that insurance carrier rules, laws, guidelines, and regulations change, so it's important that you do your best to stay on top of these changes by attending seminars, webinars like these excellent webinars that Discount Chiropractic Supplies puts on, and joining your national and state professional associations. And I just wanted to mention something before we get to questions and answers. I wanted to tell everybody about Target Coding's Smart Choice program. it will help you swan. For those of you that do not know what swan means, it means sleep well at night. So most of the doctors that we work with hire us because they want to prevent problems. I would say 80% of the doctors we work with hire us because they want to just make sure they're doing things right, want to maximize reimbursement. 20% of the doctors we work with are in a crisis situation. They're being audited, they've been arrested, they've had their files seized, they've already been asked for money back. Crisis situation, it's really bad, it's very stressful. So I like to focus on the 80%. We want to prevent problems. So we're all about prevention. So if you're smart, you know how to prevent fraud and audits. If you're smart, you know how to strategically build Blue Cross Blue Shield, Aetna, Cigna, United Healthcare. You know how to collect cash from many products and services. We can teach you that. Some doctors are so afraid of audits that they are underbilling, so they're losing money. If you're smart, you know how to, not to underbill. If you're smart, you know how to code to the highest level of specificity. If you're smart, you know how to prevent dual fee schedules and hire staff to help you maximize revenue. If you're smart, you know when not to use modifiers 52 and 59, because those can cause red flags. If you're smart, you know how to build time codes properly. If you're smart, you'll consider our Smart Choice program. It'll help you swan, sleep well at night. So if you want more information on that, just contact us, or you can go to targetcoding.com. All righty, so now I'm ready for any questions that may have come in.
Thank you, Dr. Kotlar, for your today's webinar. If anyone has any questions, please feel free to type them in the question and answer pane on the right-hand side, please.